Ready?
Okay.
Okay. So thanks for coming. We're going to go over sepsis again. This is our, I think, third redo in the last decade on here, the third major redo on here. So today I'm just going to go over the reason why we're doing it, some background of where we are, and what are the major changes, and hopefully get you guys out here in about half an hour. Where is my controller? Okay. So, as you know, sepsis is a big problem, and the national standards there, but for us here, it's becoming the #1 killer in the nation for the hospital patients. Right? 1 million lives a year. Mortality is 30 to 50%, somewhere around there, and it's still staying pretty high. Cost is very high too. It's one of those DRGs that has been identified as a very high cost DRG with a high morbidity and mortality attached with it. And it's also one of those DRGs where the hospitals are often undercompensated for, in which most of the cases we don't get compensated enough to cover the cost of it on there. So we looked at this sepsis from way back in 2004 and to now. So back in 2004, which was the very first evidence-based guideline came out from Annie Rivers and Surviving Sepsis Campaign. And at that point, we mainly concentrated on patients who are really just deathly ill. And the program at Hoag was the intensivist ran down to the ED, picked them up, and took care of them in the ICU. And we did that for about 3 years, and we were able to drop the mortality from 40% to 28%. But it just stayed there. It just didn't go any further. And that's when we realized that sepsis was not just an ICU problem. It happened out on the floor, it happened out in the sub-ICU, and it needed to be identified earlier. So from 2009 to 2012, that's when you guys got involved, where we added in the sub-ICU protocol, and the floor protocol, and the suspected sepsis protocol, and the ED sepsis protocol in there. And with that, in 2009 to 2012, we dropped the mortality from 28% to 13%. And along the way, by doing it right and by treating the patient early, we actually dropped the length of stay by 5 days, and we dropped the cost of care by $7,000 a case. Okay, so we hit a home run essentially, in which we improved mortality, and we decreased costs and decreased length of stay at the same time. And usually in healthcare, if you get one a decrease in outcomes, usually the cost goes up. But in this case, it didn't. And mainly is because what we did was that we tried to simplify this very complex pathway and remove as many obstacles as possible so that you guys can recognize the patients and then get the infrastructure and the help in hand to get it right. And since then, we realized that 90% of our sepsis are activated in the ED, okay? And right now, in the Surviving Sepsis Campaign, there was a recent upgrade in February and March of this year, where they now concentrate on the first 6 hours of care. First 6 hours of care can change the clinical trajectory of the patients as they come into play. Previously, on the prior Surviving Sepsis Campaign, you looked at the 6 hours, then the 24 hours, and then the 48 hours in there. Now everybody's concentrating on the first 6 hours, because the truth of the matter is the earlier you recognize them and the earlier they get salt water and antibiotics, the better they go. And I think in our own experience here, we've seen that over the years. Over the last 3 years, we know that the volume of resuscitation has increased from like 250 cc's on average to now about 2 to 3 liters. And we've seen that patients who came in with lactate 3.5, repeat later, becomes 1 or 2, they got more stabilized, and instead of being admitted to the sub, they're admitted to the floor. Instead of admitting to the ICU, they're admitted to the sub. Or even they get admitted to the ICU, they stay shorter because I don't even have to put a line anymore by the time that you guys got to them initially. So we recognize that. And during this time, as I said, during this mortality decrease, it wasn't because we recognized more people and just diluted the mortality down. The Apache score for the patients, which is their severity score, went higher for the ICU. You're admitting patients, initially we were Apache of 18, we went to like 21. The Apache score for the patients on average in the sub-ICU was around 17, and the floor was around 14 to 15. And those Apache scores stayed the same, except the mortality decrease on there. So it wasn't like we just say, oh, hey, we're just adding less sick patients, and that's why. If your patients are just as sick, you're able to solve it on there. So that's where we are right now, is trying to concentrate the first 6 hours. And the first 6 hours is the most difficult part of this. Why? Because if they're in the ED, think about the handoff that has to happen on that point, right? You have to hand off the recognition from the ED physician to your team or my team, and also if the patient deteriorates, then it could be your team to my team afterwards. Nurses have to hand off the information. How much of that fluid did you give? When did you start the antibiotics? Did the lactate happen? All of these sorts of things. So it's a lot of handing off of information. And if we can get the first 6 hours right, then a lot of things will go right with that. Okay. So here's where we are at Hoag. Last year we had 1,365 cases of sepsis identified, coded for. This is in the DRG 870, 871, 872. We have 500 cases of pneumonia, 319 cases of CHF, and 375 of AMI. If you really think about it, pneumonia admitted to the hospital already is a sepsis. You got pneumonia with SIRS criteria, that's sepsis. So we're talking about really about 1,800 cases here. So it dwarfs every other diagnosis that we have in hand. And the mortality is also several folds higher than what we had in hand otherwise. This nationally is 30 to 50%. We worked hard in the last decade to get it down to 13%. It's still 2 to 3 times the mortality of the others in here, right? So what we want to highlight is that this is a big problem that's coming in. And this number is going to go higher and higher because the patients who are at risk for sepsis, age is one of their biggest co-founder in there, and patients over the age of 65 have 10x the chance of getting sepsis than the other on there. And that's just the statistics on there. And guess who's coming through? The baby boomers. 80 millions of them are coming through on this. So we're going to be seeing more and more sepsis, right? We've already seen that in, if you look at the CCU, 10 years ago it used to be post-stent there in the CCU. Now there's no cardiac patients in the CCU anymore. It's really a critical care unit. Most of those guys are multi-organ failure, with the predominantly sepsis is their issue on here. So it's our #1 cause of mortality here in terms of percentage of mortality rate, and it's also the number of deaths. Right? Nationally, it's only 1% of the admissions to the ICU in most hospitals, but it represents 17% of the deaths. Okay, so this is something that we can't just sit around and say, maybe we'll wait on it, right? Okay. All right. So we've been doing pretty decent though, right? Back in 2007, we were at 40% mortality, and over the years, as we put in our program, the mortality has been decreasing on here. So I think the good work between the collaboration between the ED, the hospitalists, and the intensivists, and the nurses, and it's a multidisciplinary team to get this thing running, has been working well. Okay, has been working well, and the goal is this year is to decrease the mortality by another 1% and decrease the cost by 1 more %. Okay, our cost, like we said back in 2009 to 2012, we decreased at $7,000 from $28,000 a case to $21,000 a case already. Now they want to do 1 more % to show whether or not we can work together and squeeze the fruit a little bit more out of this. So the cost for sepsis is all related to nursing care. Okay, nursing care is the #1 cause of sepsis in there. It represents 50 to 70% of the cost in there. So it all comes out because it's the location of care. If they're in the ICU, it's $2,000 a day. If they're on the sub-ICU, it's $1,000 a day. And if it's on the floor, it's $800 a day. And 50 to 70% of that cost is nursing care, right? So this all goes back to the thought that if you get the first 6 hours right, if you get the first 6 hours right, and you identify the patients early enough, you give them the right antibiotics and the right fluids, you can change that trajectory so that when they're into any of these floors, the sooner you can get them downgraded to the next level of care, that's where the cost gets written out. But you're not sacrificing outcomes by moving them down. It's because you're treating them well enough that they are improving, that you're moving down to the right level of care, and therefore we're saving on this. The initial reason for us to do sepsis was not to save cost, right? Cost was something that we measure on the other side. I was expecting cost to go up, but luckily for us on here is that by doing the right thing and removing all the non-value added, the extra fat that was standing in our way, we actually end up with better cost profile on these patients on here. So what we're looking at is that if we do this right, in the last 3 years we've already run out about a day and a half of stay in the ICU, about a day or so in the sub and about 2 days on the floor, something around there. Right? If we do this right, we can bring out a little bit more length of stay on average with these patients. Okay? And this year so far already, as of July or June, we've already dropped the cost by another 0.8% already. Okay, so this kickoff here is meant to get us over the hump. The mortality of decreasing by 1%, I think we're there already this year. Okay, so we've hit our goal already because of everybody working on this. And these numbers here is mainly because more and more people are getting identified and then being placed on the sepsis protocol. Way back when we started in 2007, I think it was, I don't know, I forgot, 30% or 20% of people using the sepsis protocol, and now we're at 70 to 75% of people using the sepsis protocol on there. So the more you use it in there, the better this number gets on there. It's not going to get to zero, obviously, and we can't add lives back to people, but what we want to make sure is that if they do have sepsis, that it's identified early and treated early so that they get the best outcome. And for us, if they get the best outcome, they leave the hospital earlier, and there comes this cost savings out of this. Okay? So why change now? Why is it that we're going through part 3 of this? Part of it is the hospital, the board, the administration has deemed sepsis to be one of 4 programs that they want to see the collaboration and coordination of care happen between our 3 groups to show this. We're being measured together on this one. The 1% mortality and the 1% cost change is all upon us. It's all upon us. It's not about what happened in the ED and being pushed over to the floor or the ICU. We're all responsible together for this one cost in there, on there. And so we're going to have to work together to do this right on here. And we have been. It's not like we've been doing it wrong, as you can see from the graphs, that we've been doing it right. We're just going to have to be a little bit more what we're doing on this. Also, there's an upgrade to the Surviving Sepsis campaign in which the fluid boluses are changing from 20 cc's to 30 cc's, so you have to give more fluids on there. And then there's some criteria changes too. So the goal and metrics for the remainder of this year is to standardize the screening and improve compliance on that very first 6 hours of sepsis, shift the patient from severe to non-severe as fast as we can, reduce the cost, and reduce the mortality. Okay? So in June and July, we're going to focus on hour 1, 2, 3. Okay, 1, 2, 3 is mainly the ED physicians recognizing it and starting the right protocol on here, and then in August and September we'll work on the handoff between the ED to either the hospice or the intensivist, and also getting them into the hospital fast enough on there. Okay, so the first 3 hours is that the first thing is the recognition. So how do we help you guys recognize it better? So we're coming up with on the next slide, which is the workflow for you guys to use to recognize them better. But once you recognize that the patient may have sepsis, then the first 3 hours is obtain the lactate level, get the blood cultures, administer the right antibiotics. Okay, it's just not administering antibiotics. For every hours that the patient does not have the right antibiotics on board, mortality increased 6%. 6%. Okay, so make sure that you pick up the right source, or think you got the right source on there. Make your best guess. We're going to have to go broad initially, because if you're covering it, then you're fine. If you're not covering it, then for every hour that they're not covered correctly, is 6% mortality increase for sepsis. And then the new changes. Previously, we were at 20 cc's per kilo on the fluid boluses for patients who are hypotensive and lactate greater than 4. Now the recommendation is 30 cc's. Okay, so we're saying that if they have sepsis and they're not hypotensive and the lactate's not greater than 4, stick with your 20 cc's fluids. But if they are hypotensive or the lactate's greater than 4, you have to increase it to 30. Okay, clear on that? We'll go with that again. Okay. Completed within 6 hours, you need to get the mean above 65. And if we're in the ICU on here, because we're on pressors and stuff like that, then I got to get the CVP above 8 and the SVO2 greater than 70. The remeasure lactate is something that both the hospice and us follow on there. We're looking for ideally a 50% decrease in your lactate level by the 6th hour. That shows you that you're perfusing well on there. There's also a study that shows that if you drop 20% every 2 to 3 hours, that you're going the right direction too. So the guidance for lactate is that you need to show it clearing on there. At least minimum of 20% goal for us is trying to get a 50% decrease by the 6th hour on there. And if they're not, and if it's on this way up, then the patient is not responding to the resuscitation, because the cardiac output or the perfusion is not there, and therefore they may need to come back into the ICU for invasive monitoring and other items to try to get their perfusion better. Okay? Alrighty, so here's the new pathway, and it's a little bit busy, but let me just break it down to each of the sections on here. Okay, this is going to be made into poster size, and it'll be we're getting 100 of them.
I think 50. We're going to concentrate in the ER.
Yeah, 50 of them, and basically we're going to turn this. The EE will be wallpaper by this on there, and
Yes, it will.
and we'll possibly put it into some key areas around the hospital too. But this is also going to be hyperlinked onto the order set, so you can open it up and look at it. If you want, we can send it to you as a JPEG and put it in your little smartphones too, if you want on there. And if you want to make T-shirts out of it, we're fine to do that too.
That's
Okay?
good.
All right. So the first thing is that, most important is that, do you think they have sepsis? Right? I mean, infection. Right? That's the first piece on there. Don't worry about the search criteria yet. In your history, in your physical, and in the initial lab, do you think they have an infection as the pathology? That's why they're here. If they do, then we've increased the search criteria from 2 to 3. Now you need 3 before we can call you sepsis, right? So we talked it over with ED. Remember that we have 1365 cases of sepsis, 500 cases of pneumonia. If you add them together, it's like 1,800 cases. We know that you're probably filtering about 3x that, 6,000 patients to get to that 2,000. So we don't want to over-process. So one of the things we said was like, okay, you need 3 now to enter into this. And if you get 3, then it's a fluid bolus. And in the course, and we recognize that it's dynamic, if they're in the ED and you initially give them the 20 cc and they have 3 serves, but then later on they drop their blood pressure or the lactate comes back greater than 4, at that point you need to flip them over to their, we'll send it to you. You know what I'm saying?
I'm just going to take a picture.
Yeah, so if they get hypotensive along the 3 to 4.5 hours on average that they're in the ED, you need to switch to 30, okay? Average length of stay for the patients in the ED now for sepsis is 4.5 hours. So the first 3 hours is really down there for you guys on there. If they don't become hypotensive and this is all they have, then we say consider med-surg or a tele-admission, which is what you guys have been doing anyways, right? That this is how you've been processing, and it's been really good because as you can see from our previous one, that the length of stay in each of the units has been pretty consistent. You know, we're averaging about 5 days when they're admitted to the tele, 7 or 8 days when they're admitted to the sub, and about 11 days when they're admitted to the ICU on there. Okay, second piece is that if you think they have sepsis and they only meet 2 criteria, but the labs come back or their creatinine is greater than 2, their lactate is greater than 2, they have altered mental status, they're destatting on room air less than 90%, they have a coagulation profile that shows that the platelets are dropping, or the INR is elevated, or the bilirubin is elevated, then they have end organ failure, and then so 2 plus 1 also equals sepsis, right? So the previous one was mainly just vitals criteria and a WBC. On this one here, if you have evidence of end organ damage and 2 search criteria, you're back also into sepsis protocol, and it's 20 cc's per kilo, unless you're hypotensive or lactate greater than 4, which is then 30. Okay, and if you have this, then we can say this should be really tele or sub, right? Tele or sub on there, and probably the more of these you have, the more. The interesting thing is that in the triage, so far in the last 3 years, we've been able to demonstrate that, if you went to the ICU, on average, you had more organ dysfunction. If you went to sub, you had less organ dysfunction, and you went to the floor, you had like 0 to 1 organ dysfunction. So you guys have been doing a really, really good job at triaging these patients already on there, and then we don't want to discourage that. And these were the criteria that we were using. So if it's greater than 2 but less than 4, consider tele or sub. Most likely, greater than 3, you guys are putting them into the sub anyways. And then you watch for the clearance of the lactate, and you watch for their vitals and their responses to the antibiotics, and if they get good enough, move them down to the next level. Okay. If you have A and B, and they're remaining hypotensive despite the 30 cc's bolus, and this is where they go to the critical care unit, or if their lactate is greater than 4, they go to the critical care unit on there. Okay. Now what we're recommending is that ED place the ED order sets, and then your group or our group place the bed placement order set on there. And I would suggest that you wipe out what the ED write and really just use yours on there, because part of the reason is the ED antibiotics only last 24 hours. So if you think that their antibiotics is there and you don't put your own antibiotics, it expires on there. So wipe out the ED and put your order sets on there. Now, we made some significant changes to the order sets to help you out on this. On the bed placement order set, we added other items that you normally have to use on the other bed placement order set. So pain medications there, insulin links are there, respiratory albuterol Atrovent stuffs are in there also. And what we're looking for is if you're using the order sets now in the next couple months and you think there are other things that need to be added so that it helps you, let us know and we'll see. We have IT on board here to help us out. We can make changes to the order sets on there. Go ahead.
Andrea, on the last two slides, I noticed it says like sepsis clock starts.
Yes.
There's gonna be somebody called, which is I assume the
Yes.
sepsis nurse. Does that happen anytime we use a sepsis pathway?
Yes.
So it's not us actually telling someone to call a sepsis nurse?
Robin?
So the ED sepsis order set, when they initiate it in the ED, there is a pre-checked order that says,
Call the sepsis.
start sepsis time clock and call
RC.
53131 to call a code sepsis.
But that's
On
only
your
on
bed
the-
placement
yes.
order sets, we don't start the time clock on that because 90% of them start in the ED. But the new order sets, you're gonna have the option to start the sepsis time clock. And those are for
If the patient
the,
starts on the floor. Right?
Exactly.
So.
But it's not an auto check. We
It's
would
not an
have-
auto check
it's-
because sometimes you're picking the patient up after the ED, which is the majority of the time. But sometimes the patients get septic on the floor after being admitted already. And at which time then you check off that thing to start the clock there. Okay, so the clock starts with the ED and then the clock continues with us. But if the patient
On
came in
the
for a
floor.
different diagnosis and then developed sepsis in the hospital, then you start the sepsis order and the clock starts there. Okay. The clock starts when you start the protocol, which means that is when you recognize the patient. We don't ding you for, hey, the guy came in with a fever and sitting on the floor, and that's not 0 times 0. It's when you recognize it is when we start the clock.
So if a patient's on the floor, not doing well, I initiate it on the floor.
Correct.
Is there a reason why I wouldn't check that box? I mean, is there a
No.
reason why it's not, no?
No,
Okay.
there's not, but you would check that box, but right now that same one is being used
All right.
right following the ED. And majority of the time, you're using it after ED. So that's why we left that unchecked on there. The other thing is that if you were to, the other confusion that we had to work out was pneumonias, right? You had pneumonias with all of their core measurements and so what we did was the following. On the regular pneumonia, we suggest you use that for the simple patients in there. But on the pneumonia set now, we also have in there a box for the 20 cc's per kilo bolus on there. And also a checkbox there that if you think the patient's in sepsis, check it off so that we can pull them into the same pool to review on there. Okay? On the sepsis order set, if you choose lung as the source, then the antibiotics on the lung set has already been matched with the antibiotics in the pneumonia set, so you shouldn't get dinged for picking the wrong antibiotics. On top of that, the core measure for pneumonia is also included in the sepsis on there. And we also have attached to that so that the pneumonia nurse knows that if pneumonia is chosen in here, that this gets followed by the pneumonia set too. Okay.
In the ED, when we're working up and looking at a possible pneumonia, I don't
We
think
didn't
there's-
change your ED order set.
Yeah, I
The
don't think there's a
measurement-
lactate
yeah.
on that list to check. I mean, you could free check it,
Correct.
but it's not automatically checked.
Correct, it's pre-checked, and that's one of the things is that, you know, we put it out as a pre-check right now, but in the next couple of weeks, once we launch this, if it is that you're feeling that that should be an auto check, I think Greg brought that up as that they prefer to have it as an auto check on there. Some other people push back and said, no, not everybody needs it yet, and so we did a partial compromise right now. Everybody that you check off for sepsis, they're gonna pick up a rainbow plus a gray top. It goes down to the lab. The lab keeps the gray top on ice for 4 to 6 hours. So if you wanted to add a lactate later on, you can't. You can check off the lactate right there, and you'll get the lactate. But if you don't think the patient needs the lactate yet, because you're not quite sure whether or not the diagnosis is that, you can just send it. You can be assured that it's already down there, and then later on, if you do, then it only takes them half an hour to process it. Okay, so we'll come back to that if ED feels that really that should be a checkoff because we need the information regardless. Because the truth of the matter is, the patient can have normal vitals, but if the lactate is 3 or 4, you're a lot more worried about them because a lactate of 4, greater than 4 with normal vitals, has a 40% mortality, roughly 40% mortality already on the survival. And then if it's 2 to 4, it's roughly 25 to 30% mortality just by itself.
I mean, I would vote just to have a pre-check because I'm sure, you know, we have these conversations, right, where we ask you, is the lactic back? And, oh, I don't know. And then sometimes there's a delay of time where we're like, well, I really want to know the lactate before I decide which
Yeah,
bed.
because a lot of times you call a code 10, you know, a guy comes in with tachycardic, and he's an elderly gentleman with AFib, and, you know, he turns out to be septic down the road.
Correct.
And you're going down a whole different pathway, and then all of a sudden, you go, shoot, it looks like pneumonia in the chest x-ray, and you're...
So this first comes out on Monday, but I think, if the
Because
feedback comes
I
back...
think it also helps us with determining right from the get-go, like, okay,
Where do we go with it?
And I hate, right, sometimes we're like, okay, well, can we see what the lactic has, and then we'll decide the bed.
So the minimum would be a 30 minutes turnaround on there. But if it is that you guys feel that it's a decision point that we need to have on all the
It does help us
patients,
decide better.
well, then Robin, I think we're gonna have to take it
So
back.
on the ED order set, the lactate is pre-checked.
Okay.
So I think that
On
we're talking
pneumonia?
about kind of the ED general.
Correct.
That's what Dr. Super was talking about, was the ED general, it's not pre-checked, it's an option for them.
On
But I'm-
ED general,
but
there's
I-
nothing
what-
pre-checked.
Yeah.
It's
But on
all,
the
Yeah.
ED sepsis, the lactate is.
On ED sepsis, lactate
On
is
sepsis,
pre-checked.
but not like if you're going pneumonia, thinking
Right.
pneumonia,
Yeah.
shortness of breath pneumonia, there's nothing.
Correct. So if you initiate the sepsis, the lactate is
Right.
pre-checked. Okay, so we saw, yes.
So right now, if a person came in with pneumonia and sepsis, we can use either set of the
You
pneumonia
can
or
use
sepsis?
either set,
Okay.
but if they're hypotensive and, require more care, we suggest you use the sepsis side. If they're just, lower lobe and tachycardic, and desats a little bit, but you're not into that aspect, then they still need the 20 cc's per kilo, but you can use the pneumonia side. Now, with experience over the next 3 to 6 months, we may just meld them together and just say, look, let's not confuse the crowd. In there, let's just say that if you are pneumonia, use the sepsis, but check off pneumonia side, and we'll have the nurse follow that way too.
Let me just clarify, because on the pneumonia pathway,
Mhm.
there's an auto checkbox for the pneumonia NP to know that that's the patient's in-house.
Correct.
Is there something on the sepsis that if the source is pulmonary, because it just helps the pneumonia NP
Right. Robin,
identify those
At the very
patients.
top of every sepsis order set now,
Uh-huh.
is a checkbox that says pneumonia, core measures. So if you feel like pneumonia, the lung is the source, then you would need to check that box.
And then with there, that's when it checks off for the pneumonia nurse to go.
I'll have Brian follow up on that.
Yeah, okay. So what we're saying is that, try not to put the sepsis together in your own brain and fill it up your own. Please use the protocol. The reason why is because we have all of the logic built into SCM right now that will give us the feedback mechanism in terms of reporting. So we can get all of the sepsis patients out and give a report back 1 week later, in which we can tell you how many patients you have, what's your compliance rate, what's their mortality what's their length of stay, and so on and so forth. So I can return that back within a week if you use the protocol and you use the sepsis orders on there. If you don't, then we're going to have to do it manually, trying to figure out those guys on there. There is one other thing that we change. If you think they're sepsis, and Patty, you admit the patients, and 24 hours later you say, no, this is pancreatitis, there has nothing to do with sepsis, you can go to the order and tag and type in not sepsis, right? Not sepsis. What that does is that it tags the patient, and we remove that from the measurement in the background, and then you can
Where would I enter that?
in the order,
Like a nursing order?
You just
in the
enter
nursing
not
order,
sepsis.
not sepsis.
As a freehand text?
Not a freehand text. There is an order that says come out sepsis. You put in the word not, it will come out not sepsis.
Or if you put in the word sepsis, it'll come up and you can choose it.
Yeah.
Is that new?
That's new.
It's
Because
new.
we want to have
It
a
just
vitamin.
tags them.
It tags them. You still have to remove the actual orders, but what it does is it tags them. Because right now, when the patient is fine now, you're removing those orders for sepsis. So we don't know whether or not that sepsis is real or not, right?
Okay.
So we need to know whether or not the patient is, we're overcapturing many patients on there. So let's say we have, next year also we have 2,700 patients in there. And everybody goes through this and our mortality goes whichever direction. We don't know if they're all sepsis or not. So within the course of the next 24, 48 hours on there, whoever's taking care of the patients, if it came out to be pericarditis or cancer or pancreatitis or some other reason why they're having this collagen vascular disease, you put in not sepsis, we take them off of the measurement list on there. Okay. The other thing we're going to report back to you is everyone that comes to the ED within 6 hours.
That's still yet to be
Okay.
defined.
Okay. But in a period of time that has 3 search criteria. So at least we can report to you, these are how many potential patients that you're seeing on a monthly basis, of which the sepsis comes out of. Because we don't really have a great handle. We only have the handle of, hey, you've identified them, but we don't know how many potential people we may be missing or not missing. And we don't know whether or not we're over-processing or under-processing these patients on here, right? So this is one of the biggest problems in all of healthcare for sepsis is that people say, well, do I count a UTI or not? Well, yes, you do. If their UTI is bad enough for them to be hypotensive and going into the hospital, they're septic. Do I count pneumonia or not? Yes, you do, because they are truly sepsis. So we don't really have a good count yet on there. We can tell you afterwards where is the source of the infection. Is it the belly? Is it the urine? Is it the lung? Is it blood on there? And then we can break that out on there. But most people are still not considering sepsis if you have pyelonephritis. But if you're pyelonephritis, you're tachycardic, you're febrile, and you're potentially hypotensive or dehydrated, they are sepsis already on there. It's just that we don't call it that yet on there. Okay. Again, standardized screening criteria, 20 cc's for everybody that meets sepsis criteria, and 30 cc's if their lactate's greater than 4 or they're hypotensive on there. Oh, sorry. We did a couple other things too. On the pre-checking, previously, whenever you guys ordered from the ED at least, the sepsis, the patient get gangbang basically. They get Foleys, they get ABGs, they get DIC panel, MAGFOS, stuff that may not. So all of those now are unchecked. They're unchecked. So because we're asking you to recognize it earlier, we're not asking you to assume that everybody's going to the ICU. Okay. So a lot of things are unchecked. You can still check them off, but as needed in there, so we don't over-process. So that's one of the things that kind of control the costs in here, is not to give everybody an ABG when they may not need it, and not everybody. So the only thing that's going to be pre-checked is procalcitonin, CBC, chemistry panel, chest X-ray, EKG, UA, right? And lactate.
Blood
and
cultures.
cultures. Yeah, those are the main ones.
And then is the automatically the 20 milligram per kilo checked
Yes.
on it?
Yeah, and here's the other part about the 20 cc's per kilo. So that's the default 20 cc per kilo, and then you would have to actively change it over to 30 if they're hypotensive or lactate greater than 4. Now, if you already have this orders in already, we're not asking you to reopen the whole order set again to just change the bolus. On the orders itself, if you grab the 20 cc's per kilo orders and you hit discontinue and reorder on the right hand, if you hit the right mouse and hit discontinue and reorder, then the choices will come up to be 20 versus 30, and you can change it there. So then you don't have to open up the whole order sets again. And again, we're looking for tricks like this. If you guys are doing a lot of these things and you're thinking, this is cumbersome and so, let us know and come up with your suggestions of how it can be done. And we have IT's eyeballs on this, and we can help make that better.
And we're keeping the 2 lines.
Yes, you're keeping the 2 lines. Now remember, 30 cc's, if you're talking about 80 kilo patients, 2.4 liters, right? And we're giving you 90 minutes to put it in rather than 60. But still, 2.4 liters on 2 lines, that's 999, 999, and something else, right? You may need 3, in which case you may want to consider 250 of albumin, that makes up about 500 cc's. So you may do 250 of albumin plus 2 liters, and that will give you the adequate amount of volume is there. Okay, and that's it. And
Thank you.
right at 35 minutes. All right, thank you very much, guys.
Thank you.
Thank you.